Thanks very much for, I'm very pleased to be here connected with you, and I wish to thank the organizers for this invitation. These are my disclosure for this talk today. As you probably know, over the last 20 years, the so-called coagulopathy of chronic liver disease underwent dramatic changes. And in fact, up to 2005, cirrhosis was recognized as the epitome of the acquired hemorrhagic diseases. And in fact, we know very well that cirrhosis is characterized by impaired synthesis of all coagulation factors, with the exception of factor VIII and molecular factor. I will come later on this aspect. And also, cirrhosis is associated with thrombocytopathy, thrombocytopenia, and probably hyperfibrinolysis. As a matter of fact, these complex defects have been historically documented in the laboratory through the measurement of the prothrombin and activated partial thromboplastin time, and also the skin bleeding time was used, and platelet count, and also finally the measurement of the fibrinolytic components of this system. Unfortunately, there was a dogma until recently on this aspect, as shown by the fact that the concept of a causal relationship between abnormal hemostasis and bleeding, which was widely accepted, as shown by the common practice to screen patients with hemostasis test, and finally to treat them in order to correct the abnormality prior to invasive procedure or surgery. Starting from 2005, this dogma has been challenged, and the new concept of rebalanced hemostasis has been introduced. There are at least three issues which can be taken as evidence challenging the dogma. Let's see first the clinical challenging of this dogma. We know very well that gastrointestinal bleeding is the most common hemorrhagic event in cirrhosis, but on the other hand, we know that the conventional coagulation tests do correlate poorly with the gastrointestinal bleeding in these conditions. And finally, as was shown by Dr. Massicot some years ago, coagulation defects do not predict blood product requirement during liver transplantation. And in fact, there were several evidence of a poor correlation between conventional hemostasis test and bleeding in cirrhosis. This is a review of the literature. I'm particularly interested in the first paper published by Dr. Yu in 1981. You see a figure from that paper. You know that the author tried to measure the liver bleeding time, that is the bleeding time directly on the liver during a laparoscopic liver biopsy in a patient. And he also tried to correlate the liver bleeding time with the peripheral prothrombin time. And as you can see here, there was no correlation at all. Now, one may wonder why PT and APTT are not correlated with the bleeding during liver biopsy. We thought about this apparent paradox, and we came to the conclusion some years ago that PT and APTT do not reflect the in vivo coagulation balance that occur in vivo, particularly in acquired coagulopathy such as cirrhosis, where in addition to the procoagulants, also protein C and antithrombin are reduced to the same extent. And finally, protein C in vitro is activated to a limited extent in the absence of thrombomodulin. You know that thrombomodulin is located on endothelial cells and much less in plasma. And in fact, protein C is activated by thrombin on the membrane of endothelial cells, where there are some receptors. The first one is the EPCR, which is the receptor for plasma protein C. Very close to the PCR, there is another receptor, which is called the thrombomodulin. This is this receptor for free thrombin. And because of these two receptors, the substrate protein C and the enzyme thrombin will come to a close contact, and therefore protein C will be quickly activated. And finally, the activated protein C in combination with its cofactor protein S is able to form a complex, and this complex is eventually able to inhibit the activated forms of factor VIII and factor 5, thus quenching thrombin generation. For many years, it has kept the attention that the plasma reagents needed to perform PT and APTT do not contain thrombomodulin, and therefore this assay, this test are not valuable in the context of an acquired coagulopathy such as cirrhosis. Essentially, we can conclude this part of my talk today saying that probably PT and APTT are responsive to procoagulant factors, as you can see here, which correspond to the ascending arm of the thrombin generation curve. But PT and APTT are much less responsive to the anticoagulant factors, which are shown here by the descending part of the thrombin generation curve. So essentially, PT and APTT can tell us whether a patient is deficient in one or more procoagulants. That's why they are used in hemophilia and allied disorders, but they cannot tell us whether this deficiency is counterbalanced by a concomitant deficiency of the anticoagulant factors, which happens in acquired coagulation disorder, such as chronic liver disease. The second evidence challenging the dogma is pathophysiological. I'm very brief here. You know that coagulation is the result of the action of procoagulants, which are contrasted by the anticoagulants. But we know that the pro and anticoagulant factors are concomitantly reduced in cirrhosis. So there should be a rebalance of coagulation in this condition. And finally, what is the laboratory evidence challenging the dogma? In 2005, we first demonstrated, provide evidence of normal thrombin generation in cirrhosis, despite the fact that this patient may have abnormal conventional coagulation tests, such as PT and APTT. And in fact, we investigated thrombin generation in platelet-poor plasma in these patients. And as you can see here, in the absence of thrombomodulin in the system, patients displayed significantly reduced level of thrombin generation with respect to the controls. And this was completely expected because it reflects the partial deficiency of procoagulants in these conditions, which is not counteracted by the partial deficiency of anticoagulants, because here there is no thrombomodulin in the system. And in fact, when we repeated this experiment by introducing a soluble thrombomodulin in the system, as expected, the control population generated much less thrombin, and this was expected because actually in the control population in this system, we activated massively protein C, and therefore thrombin generation was reduced. But actually, even in cirrhotic patient, the thrombin generation was reduced to much lesser extent, as you can see here, so that there was no longer statistically significant difference between controls and cirrhotic patients. We interpreted this result as the evidence of a balanced coagulation of in cirrhosis whenever you add thrombomodulin in the system. Later on, these results were confirmed by Dr. Lisman. He published normal to increase thrombin generation in patients with liver disease, and also by Dr. Gatt in another study which was published very soon. So in summary, we can say that coagulation is not abnormal in cirrhosis, provided that it is assessed with global tests reflecting the function of pro and anticoagulants. And what are the consequences of these findings? There are at least two important consequences which may be of interest for the audience. First, there is little value of PT and APTT to assess the bleeding risk in this patient. And second, the common practice of prophylactic infusion of prehemostatic agents in this patient should be reconsidered. And in fact, I looked at the literature over the years, and you can see that there were at least 4 randomized clinical trials using recombinant factor 7A to try to stop bleeding in patients with cirrhosis. 2 of these trials were on variceal bleeding, and the other 2 were on transplantation. Now, in all these trials, there was a poor efficacy of recombinant 7A to stop bleeding in this patient. And this supports the concept that the thrombin generation is normal in vivo in these subjects, and therefore there is no need to, optimize the thrombin generation in this patient, in spite of the fact that recombinant 7A is actually effective in shortening the prothrombin time in this patient, but no clinical effect. What about the role of platelets? Because we know that patients with the cirrhosis are thrombocytopenic, and platelets, we know they have a role in hemostasis. First of all, platelets adhere to the site of vessel wall injury to the subendothelial matrix, and this addition is potentiated by von Willebrand factor, which is heavily increased in patients with the cirrhosis. And the second role of platelets is in thrombin generation, because as you can see here, on the surface of activated platelet will adhere some vitamin K dependent coagulation factors, which speed up thrombin generation in this mechanism. So Tom Lisman, again, some years ago, provide evidence that elevated levels of von Willebrand factors may compensate for the functions of a number of platelets in cirrhosis. In other words, patients with cirrhosis are thrombocytopenic, but because of the increased levels of von Willebrand factor, which is the adhesive protein, this defect is partially compensated. And this was demonstrated in a flow system, which is mimic more or less what happens in vivo. The year later, we produced evidence on the role of platelets in thrombin generation, and essentially we concluded from our experiment that platelets from patients with the cirrhosis seems to be qualitatively adequate to support thrombin generation, provided that the number is adequate. Finally, I would like to convey with you this cartoon, which is a sort of summary. In the healthy subjects, the balance of coagulation is very stable because in this subject there is a great excess of procoagulants, anticoagulants, and platelet. But in cirrhosis, the situation is quite different. The balance of coagulation is very unstable because here we have a partial deficit of procoagulants, anticoagulants, and platelets, and therefore the balance may tip towards hemorrhage or thrombosis in the same patients, depending on the prevailing circumstantial risk factor to which the patients are exposed. So now the question would be, why do patients with the cirrhosis occasionally bleed if thrombin generation and hemostasis is rebalanced? There could be two explanations. The first one, as I mentioned, is that the restored hemostatic balance in cirrhosis is not very stable as it is in healthy individuals, and therefore steroid alteration may lead to hemorrhage or thrombosis. This seems to be paradoxical, but it's the situation which happens very often. And also, we should understand that there may be underlying conditions in cirrhosis which may favor bleeding. For instance, you know very well that portal hypertension may be a cause of bleeding, for instance, for varices, endothelial dysfunction, bacterial infection, may be hyperfibrinolysis, and renal failure may be additional factors triggering hemorrhage. So I would say that therapeutic intervention correcting these abnormalities probably are much more effective than correcting the coagulopathy itself. And finally, the last part of my presentation is concerned with the cirrhosis as a prothrombotic condition, which started to emerge at least 10 years ago. The first evidence of this fact is this epidemiological observation made in 2006 by Dr. Northup in the United States. They show that the coagulopathy does not fully protect hospitalized patients with cirrhosis from peripheral venous thromboembolism. Following this first paper, there were at least two case control studies, population-based case control studies made in Denmark, which showed as a conclusion that patients with the cirrhosis had a relative risk of venous thromboembolism, which is close to 2. And when the analysis was restricted to unprovoked VT, the relative risk was even higher. And the last paper in this aspect, epidemiological evidence, is this paper in which the authors investigated the risk and outcome of venous and arterial thrombosis in patients with cirrhosis, again, in Denmark. Essentially, the authors found that the relative risk of venous thromboembolism in this patient is nearly 2, as you can see here, with the relatively tight confidence interval. And they also found that the compensation increased the risk of acute myocardial infarction. And finally, following thrombosis, patient with the cirrhosis seems to have a higher 9-day mortality than non-cirrhotic patients. So what are the implications of the procoagulant imbalance in cirrhosis? First of all, I would say that the secondary prevention of venous thromboembolism with vitamin T antagonist or weight heparin should be more extensively used whenever there is indication in patients with cirrhosis. I must remember the audience that until recently, the use, for instance, of vitamin K antagonist was strongly contraindicated in this patient. And also, we believe that the primary portal vein thrombosis prevention should be considered in patients awaiting for liver transplantation. And in fact, there were some clinical trials assessing the value of this prophylaxis. And Dr. Villa, in fact, published some studies some years ago in which she demonstrated that the use of low molecular weight heparin is really useful to prevent PVT in patients awaiting for liver transplantation. And also, I would say that some other non-coagulation thrombin effect should be considered in patients with cirrhosis. Thrombin may have some other effects which are not directly related with coagulation, and this should be taken into consideration in this patient. And I hope that there will be future research in this field. And these are my take-home message, and I conclude my presentation today. According to the evidence I showed, the concept of rebalance hemostasis questions quite dramatically the old therapeutic strategy in cirrhosis, so this should be reconsidered. For instance, there is no value to screen patients with PT and APTT because these are not valid in this context. And there is also no value to correct the abnormal hemostasis prior to surgery, as I shown before. And patients with cirrhosis finally are not naturally anticoagulated, as it was believed for many years until recently. I finish here and thank you very much for your attention.